So next speaker is a national expert in complements, and yesterday actually she was called as the complement queen. She has been doing a lot of work on complements, atypical aHUS, C3 nephropathy, and she will give us next 15 minutes about recurrent atypical aHUS and C3. Dr. Anjujava.
Thanks, Tarek. Good morning, everyone. It's a pleasure to be here, and Tarek has tasked me with talking about atypical hemolytic uremic syndrome and C3 glomerulopathy. So over the next 10 to 12 minutes, my goal is to give you all an etiology, the genetics, the prevention and management of these conditions. These are my disclosures. So to begin with, atypical hemolytic uremic syndrome, or aHUS, is a thrombotic microangiopathy, which really defines a pathological process that causes thrombotic occlusion of the microvasculature. And as you see on the left is a healthy capillary, and on the right is this capillary which is damaged because of endothelial injury causing a TMA. The disease is characterized by non-immune hemolytic anemia, thrombocytopenia, and end organ damage, in which kidneys are predominantly involved, although it's important to remember that aHUS is a systemic disease and it can cause cardiovascular complications and stroke. Now, C3G, on the other hand, is a glomerular disease. It's a glomerular pathology which is characterized by the deposition of C3 in the glomerulus in the absence or near absence of immunoglobulin deposits. And the diagnosis of C3G can only be made on immunofluorescence, where the criteria is that the C3 staining should be 2 orders of magnitude higher than any other immunoreactant, which is shown here. On the left is this IgG staining, and on the right is this bright C3 staining, which is roughly considered 2 orders of magnitude higher. Importantly, C3G is actually then subdivided into 2 types, which is dense deposit disease and C3GN, and this is based on electron microscopy and looks at the type and the location of deposits. And making this distinction is important because dense deposit disease in general is thought to have a higher recurrence and a faster allograft loss rate after transplant. Now, both of these diseases are prototypic complement-mediated diseases that occur due to a dysregulated complement activation, primarily of the alternative pathway. And the etiology of this dysregulation is about 40 to 60% of patients you would identify a mutation in aHUS, and in up to 20 to 30% a mutation in C3G in one of the complement proteins. Now, aHUS is also considered a disease of incomplete penetrance, which means that despite these patients carrying mutations, there is often an environmental trigger that is required, and that trigger is often multiple things. It could be an autoimmune disease, it could be transplant surgery, the drugs that we use like CNIs, infection, CMV, BK, pregnancy. And the risk of recurrence of any of both of these diseases really depends on the underlying complement abnormality. Now, prior to us having the first complement inhibitor, which was in 2011, transplanting a patient with aHUS was contraindicated because you knew that the disease was going to come back in the transplanted kidney and the patient would lose their allograft. But since we've had the C5 inhibitor for the last 10 or 11 years, and there are multiple other drugs in trials that I'll talk over very briefly, we have been able to successfully transplant these patients. So as I mentioned, the etiology of both of these diseases is either a loss of function mutation in one of the complement regulators, or a gain of function mutation in one of the complement components C3 or B, or there could be acquired factors, most importantly factor H autoantibodies in aHUS, which are often associated with deletions in factor H-related proteins. However, acquired factors are a much more important cause in C3G, the most common being C3 nephritic factor, which really is an autoantibody against an enzyme called C3 convertase, which stabilizes the enzyme and continues to convert C3 to C3b, and thereby keeping the alternative pathway active. In about 50% of patients, you may identify a C5 nephritic factor, which is an autoantibody against an enzyme which is further downstream in the complement pathway called the C5 convertase. A well-established association now of C3G is with monoclonal gammopathy. Importantly, in older patients who have been diagnosed with C3G, it is critical to identify if they have a monoclonal protein. It is speculated that these monoclonal proteins may function like autoantibodies like factor H or nephritic factors, and that is how they impair complement regulation. And it is critical to identify these patients before transplant and treat the monoclonal gammopathy, because if not, these patients recur after a transplant very aggressively and very soon. And then there are individual and rare case reports of autoantibodies against factor B, CR1, which we don't know much about them. But if you don't find a cause, and if there is a lab available, and if you're able to test, something to keep in mind about these other autoantibodies that may be present in these conditions. So the first step to really preventing recurrence of these conditions after a transplant is to identify patients who actually have these conditions at the time of pre-transplant evaluation. And certain characteristics of patients that you must do testing for complement involve, of course, any patient who has a history of TMA or thrombotic microangiopathy in the native kidney, anybody who's had a C3G as their cause of end-stage kidney disease. Now remember that C3G is a relatively newer terminology, and this was really, it was an outcome from MPGN. And so if you have a patient who had a biopsy prior to 2013, before we really figured out that this was C3G, those patients come in with biopsy diagnosis of MPGNs or post-infectious GN. So it's very important to look at that biopsy and not assume that that was MPGN, and those patients need to be tested. Anybody with a significant family history of any of these conditions, or for that matter, a young patient with an unexplained kidney failure should undergo testing. And you could argue that those patients probably need more wider testing than just complement. There are two other categories of patients that we have identified in our practice here that definitely should undergo testing. One is those young patients who have been diagnosed with hypertensive nephrosclerosis as the cause of kidney failure, which never truly causes kidney failure by itself, should be tested for complement. And young women who've lost their kidney during preeclampsia or HELP syndrome and they never recovered after delivery should also undergo testing. And this is primarily based on our own experience here, where we've tested these patients during pre-evals and we've found complement mutations. There are two other extrarenal manifestations that we often forget about in C3G. One is called the acquired partial lipodystrophy, which is very rare, but retinal drusen is a fairly common extrarenal manifestation of C3G. And if you have a young patient who has drusen or has vision abnormalities, it is very important to make sure that they are being tested and you're looking for C3G in those. We have a very classic case in our practice here of a really young woman who had drusen and who was misdiagnosed with lupus and another time with post-infectious GN. Ultimately, we found a pathogenic mutation in her. So again, something we don't talk about often because drusen is often associated with older people with age-related macular degeneration, but a younger patient with drusen should be tested for C3G. So when I talk about testing, I'm looking at genetic testing as number one. It's critical to do that during pre-transplant evaluations if you have a patient with one of the characteristics I mentioned, or if you've identified a patient after transplant and you've found a disease which is either recurrent or de novo. So genetic testing is important to not only make a diagnosis, establish a diagnosis, it'll inform the etiology of disease in your patients. It provides prognostic information regarding what is the risk of progression to end-stage kidney disease, what is the risk of relapse, risk of disease recurrence. And very importantly, from the transplant standpoint, when you're evaluating donors, if you have a living-related donor for a patient for any of these conditions, it is critical for those donors to undergo the same level of comprehensive testing that you would do your recipient. And this genetic testing really involves these common 13 genes that any CLIA or CAP certified lab would do. This is the panel here. And most of these variants are then reported based on the American College of Medical Genetics guidelines. And you would get a report that would identify these variants as one of 5 categories: pathogenic, likely pathogenic, benign, likely benign, or a variant of uncertain significance. Now, if you have a patient with the underlying phenotype of one of these diseases and you identify a pathogenic or a likely pathogenic variant, the association is clear. However, the big challenge occurs when you have a patient with one of the clinical phenotypes, but you identify a variant of uncertain significance. And it is very, very important that variants of uncertain significance undergo further testing to define whether that variant is significant or not. And even now, I get consults which this is the biggest challenge I see, where if during pre-evaluations or post-transplant a VUS was identified and was brushed aside as being of not being of significance just because it wasn't labeled as pathogenic or likely pathogenic. I cannot stress enough the importance of going after these VUSs to really clarify if they're pathogenic or not. And there are multiple ways to do that. I trained here at WashU in a lab where I learned how to make these variants recombinantly and do complement functional assays. Of course, those assays are very labor intensive and they take a long time. However, there are multiple other ways you could go after these VUSs. Number one would be just investigating the different complement biomarkers. And those tests are available in multiple labs throughout. So in addition to the genetic testing, you could test for functional assays like CH50, AH50, looking for antigenic levels of complement proteins, looking for those acquired factors, the nephritic factors, factor-rich autoantibodies, and importantly in older patients looking for monoclonal gammopathy. In addition, there are a number of labs that would also let you do some complement split product testing. And if you don't find a genetic etiology and you don't find any of the other tests that I mentioned in my previous slide, just looking at these biomarkers will give you an assessment of whether complement is active in your patient and where in the complement pathway that defect might be. And then, like I said before, in the absence of anything else, there are these rare autoantibodies that you could test for. Ultimately, all of this testing is important to really define the risk in your patient, the risk of recurrence, the etiology, and to really define prognosis. And this is a flowchart that I've designed to really put all this testing together. And this involves where if you have a kidney transplant patient, there are two main components. You have the genetic testing, where if you have a pathogenic, benign, or a VUS, and how you go down that way. If you have a VUS, you have to go down and investigate whether it's defective or not. And the panel on the right here really shows all the other complement testing that you could do. Now, and I put this in a way because I know that not all centers have access to genetic testing first, and I get consults a lot where, you know, the antigenic levels or the biomarkers have been done. So really depending on what is available to you, you know, you could go either way. But typically our protocol is I start with genetic testing. If I identify a mutation, I would check an antigenic level. If I don't find a genetic mutation, then I would use the panel on the left. But ultimately, the goal is to really get this information together, define the antigenic, the genetic etiology in your patient to really define what the recurrence risk is. And even if you haven't identified this in the pre-transplant evaluation, if you have a post-transplant patient with this testing is equally valid to really figure out what is causing the disease in your patient. And we use this information, the genetic information, then to define treatment for our patients. Again, this is something that I've put together for our practice here, and it's been published in a couple of my reviews. And this really helps stratify who you're going to treat for how long. And so on the left is the group of patients where we would keep them on anti-complement therapy probably for much longer and maybe lifelong in some patients. And this group includes those who have a pathogenic mutation in a complement protein, patients who have a biopsy-proven TMA, and even if they did not have a genetic mutation, if the nature of the disease in their native kidney was aggressive and there were not many triggers identified, those patients may need longer therapy than if they've had recurrent relapses in their native kidney, and of course if they've recurred in a prior transplant. On the right are the patients where you could potentially may not need therapy or may need it for a very short period of time. Those with acquired factors like factor-rich autoantibodies, and if you're able to successfully treat them, those patients, and they stay free from autoantibodies, may not need therapy. And then isolated MCP, which is membrane cofactor protein mutations. MCP is a complement regulator that is membrane-bound. So when you transplant a patient who has an MCP mutation and gets a kidney from an unrelated or deceased donor and gets a fresh set of MCP, you expect that MCP works fine and those patients don't need anti-complement therapy. And again, the middle column here is the VUSs. Like I said, cannot stress enough that those VUSs need further investigation. You cannot make a decision whether that VUS is of significance or not until you've investigated further, and then you can decide. In terms of treatment for these conditions for aHUS, currently the only FDA-approved treatment is eculizumab, which is an anti-C5 drug. It's basically a recombinant humanized monoclonal antibody. And it's IV drug. It's given every 2 weeks. And we have a nice protocol. And when we give these, if we know a patient who's coming in with a known diagnosis, we give it to them at the time of transplant. For obviously patients who have had a misdiagnosis or they have de novo TMAs, the drug is started after the transplant. And now we, of course, also have a longer-acting version of eculizumab, which is ravulizumab, which is basically given every 8 weeks, same efficacy. It's just an amino acid change, which has made the drug that it recycles longer and just, you have a longer half-life. But really no difference in terms of the efficacy of the drugs. And in terms of C3G treatment, we are lagging a little bit behind aHUS because we don't have anything FDA approved yet, but there's a lot coming, and hopefully in the next 12 to 18 months, we will have drugs that treat the disease. But currently, the only optimal treatment, you would control blood pressure, you could give higher doses of steroids and MMF, which of course comes with its own risk of infections. Eculizumab can be used in a subset of C3G patients. There are reports that show that if your patient has more activation of the terminal pathway, eculizumab may be helpful. I would say 30% of patients respond to eculizumab. Pheresis and rituximab can be used in patients who have autoantibodies. Again, for unclear reasons, these therapies work in maybe less than 50% of patients. And then there is more data that's come out on using a direct renin inhibitor, just giving you a quick overview of what is known. There are case reports that have shown that it is helpful in C3G. And that comes from the fact that renin actually converts C3 to C3a and C3b, and that's where the rationale is for using a renin inhibitor. However, the paper that showed that this was helpful, the doses that were used in vitro were actually much higher compared to what the drug would actually achieve in vivo. So it's hard to kind of make an extrapolation of that. And then it makes you wonder whether if a direct renin inhibitor is useful, is RAS blockade harmful, which we know it is potentially not, because it does help with proteinuria. And then we also are not sure what is the contribution of renin converting C3 to C3b versus the C3 convertase. And so there are quite a few unknowns in the area. However, there is a trial that is looking at comparing ACE inhibitors to aliskiren, and we'll probably know more about it. However, what is really, really encouraging about the field is that there are many new drugs in the pipeline for both of these conditions. We know the eculizumab and the ravulizumab. There are a couple C5 inhibitors which are not in trials just for aHUS yet, but they're looking at stem cell TAs and PNH. Then, of course, Dr. De Los Santos talked about iptacopan, which has also been trialed in C3G, and I'm looking forward to those results. Danicopan was a factor D inhibitor that looked promising but hasn't moved forward. And then, C3, we are expecting results on the C3 inhibitor to come forward as well. Two other things I wanted to touch about. One was de novo TMA after kidney transplantation. So de novo TMA in general, if you look at the reports, it's reported in about 1 to 5%, but I think the true frequency is unknown. And the pathogenic mechanisms of why patients develop de novo TMA are the usual risk factors, the triggers of the infection surgery, the ischemia reperfusion injuries, the infections, the drugs, the rejection. And typically, if this is true de novo TMA happening from any of these conditions, you would probably give them supportive therapy, treat the infection, get rid of the CNI. However, I think that I always worry about young patients who get diagnosed with de novo TMA, because my suspicion is that those young patients potentially had a misdiagnosis in the native kidney, and when a TMA is diagnosed after a transplant, it's possibly a recurrence rather than a true de novo. And I think those patients definitely should undergo genetic testing and further investigation to define whether this is a true de novo or recurrence. And finally, living donors. So when you're looking, as I mentioned earlier, when you're doing genetic testing, and an important component of that is assessing the living donors. And in general, living-related transplant, I would say, is relatively contraindicated, more for aHUS, less for C3G, primarily because aHUS carries a more higher predominance of genetic etiology. And like I said before, the testing in the donor should be as comprehensive and elaborate as you would do for a recipient, and it should involve the genetic testing with the entire panel. Now, even if you don't identify a mutation in a living donor, it doesn't entirely rule out the risk for the donor, and that is because we know the cause of aHUS in only 40 or 60% of patients, even in the recipient. So there is still that room for question where we may not have identified a cause in the recipient. We don't know what's caused in the recipient, so you really can't identify if the donor is at risk. And so you really have to make a case-by-case decision for donors. And one situation where you can potentially accept a living-related donor is if you have truly identified a mutation in the recipient, and you know that mutation is the cause of aHUS in the recipient, and the donor does not carry that mutation. And of course, it is a shared decision making. The donors and the recipients have to be aware of the risks altogether. And so with that, I'm going to end by saying that it is very, very critical to recognize your patients during pre-transplant evaluation to prevent recurrences in the transplant kidney. And if you have a recurrence in the transplant kidney, it's important to investigate widely used genetic testing, biomarker testing, complement testing to pinpoint what is the etiology of disease. And this is going to be important because there are multiple drugs that are coming in the pipeline, and understanding the etiology of disease in your patient will help you choose the right drug for the right patient, which is the bottom line of precision medicine. And of course, the big thing that we are still struggling with is the cost. So I'm hoping that with newer drugs, the drugs will become more affordable in the future. With that, I will stop and I'll take any questions.
Thanks for the wonderful talk. So, in non-academic clinical practice, if the patient they suspect they might have atypical aHUS, would a renal panel be sufficient to start the process before you go to those 13 gene mutation?
I personally prefer to do the 13 gene mutation because I think you might be missing something with the complement panel. I know that Renasight's working on making their panel full, but I think it's not complete yet.
So I'm a patient in pre-transplant evaluation with C3G, and they also have aHUS.
Mm-hmm.
So would you consider treating them?
100%.
So we need to talk to
Hematology, and yes, and you will get pushback, but it's important to understand and explain to them that this patient has C3G and monoclonal gammopathy. I have a very nice case actually when Dr. Brennan was here and we've published that, who was she was 60-some-year-old, had monoclonal gammopathy, didn't meet the criteria for this whole multiple myeloma situation, and they wouldn't treat her. But, we made the point about it, she got treated. So she was very interesting. She carried a factor H mutation, she carried factor H autoantibody, and she carried nephritic factors. It was a very unusual case. We actually made that mutation was not problematic. We treated her monoclonal gammopathy before the transplant. Her autoantibodies went away. We gave her a transplant. She did fine. Her monoclonal gammopathy recurred after the transplant, and her C3G came back with it, and her autoantibodies came back with it. So it's a very, very well-established connection. I would 100% treat the monoclonal gammopathy.
Can you please walk us through, like, if you have a de novo TMA after transplant, immunosuppression, do you just take out tacrolimus, change to Billa, or try cyclosporin, or?
Yeah, so, my take there has been that if it is an older patient, and this is entirely based on observation, that if it is an older patient, our observation is that most of the times it's related to the CNI and multiple other peri-transplant risk factors. So I think in those, even though we will send genetic testing, we do have a low threshold of switching them to Bella. However, we don't always do that in younger patients, like I said. I think the younger patients who develop this either have had some underlying genetic etiology which was missed during the pre-transplant evaluation, and I always worry about switching them to Bella because I feel like under immunosuppressing them, they're at risk for rejection, and that is going to exacerbate the TMA risk. So for those patients, we will actually keep them on, and we may add the anti-complement therapy while the genetics is pending.
Would you say during talk, as always, Dr. Chava, two comments. One is maybe let everyone be aware of your series of complement that you're offering through, is it the International Society of Nephrology?
We did put together a curriculum. Thanks, Kevin, for bringing that. We have a curriculum that I have co-chaired, and we've actually talked about complement in almost every possible disease. We've looked at complement in C3G, TMA, IgA, transplant, and these are recorded talks that are available to ISN members, and they're actually published. So if you're an ISN member, you should have gotten. If not, if you become a member, these are talks that you can listen to anytime. We actually designed MCQs just for testing and making sure that the educational component is complete. Yes, and I think they've been pretty well received. You've probably heard those.
It's on my list.
Okay.
The other thing I was just going to make a comment. You talk about hypertensive nephrocirrhosis. Is there any move to change that? It's doing a disservice to me.
It is. It is. And I have been a big advocate of making sure that every time we see that, at least in our practice now, I know that every time we see that, we do not accept that diagnosis. And I've been doing my bit to educate that. And I think it's kind of coming around. I think nephrologists around are understanding that too. But I agree that there is a little bit more education needed. I think it was not, in the last 6 or 8 months, I got a consult from a local hospital so that was an interesting case because it was a young patient who had hypertension, African American. A lot of time African American patients with hypertension ended up, getting put to the side as, okay, this is what it is. That patient also actually had left ventricular hypertrophy. So that's another thing that was assumed that this is hypertension associated. I pushed to make sure that this genetics was done, and that patient carried a factor H mutation. So if you go back into the literature, there are some scoring systems that talk about how to differentiate hypertension from aHUS, and they include LVH there, where if you have LVH, lesser of a chance of being aHUS, but I think in my experience that's not been the case. I don't think you can use that to discard anything. A younger patient, I think you have to be more aggressive.
That was great. Thank you.
Thank you.